Thank you, Dr. Stadnik, for the kind introduction, and thank you everybody for either joining us here in person or online today and giving me the opportunity to speak about revascularization and ischemic cardiomyopathy and ischemic left ventricular dysfunction. My intention this morning is hopefully to only speak for about 45 to 50 minutes or so, as I do suspect the topic in and of itself and review of the literature will stimulate lots of discussion. So I do hope to leave ample time for that at the end of the presentation. To start off and just to put us into the right context to be able to interpret the literature going forward, I want to present two similar but contrasting cases that will certainly be familiar to the vast majority of us who participate in patient care in the building. So the first is an early 70s-year-old gentleman presenting with a fairly non-specific complaint of 1 month's history of shortness of breath on exertion. As you can see, he has multiple cardiovascular risk factors, but no formal cardiovascular diagnoses, and has had no reason to have formal cardiovascular investigations in the past. From a medication perspective, not on any significant, anything significant cardiovascular-wise as well. Clinical examination, as you may suspect, given the topic, unremarkable hemodynamics, but certainly some evidence of clinical volume overload. And then biochemically normal perfusion, but with an elevated NT-BNP. So quite clear in which direction we're progressing, in our typical usual next step, aside from the acute management, is to get a transthoracic echocardiogram. Not surprisingly, what we're demonstrating is a severe and globally reduced LV systolic function with an ejection fraction of around 18%. What's certainly pertinent to point out is that his cardiomyopathy is dilated with an LV-EDD around 6.4, 6.5 centimeters, and thus suggesting or implying that this is certainly a subacute presentation, and there is certainly a more chronic pathophysiology contributing to why he's with us today. In efforts to investigate the etiology of his cardiomyopathy, one of our typical usual next steps, as we will discuss in further detail, is an invasive coronary angiogram. And once again, not surprisingly, what we see is multi-vessel proximal obstructive coronary artery disease. And what we're going to discuss over the course of the morning is how we can interpret the literature and, of course, apply this to discussions on revascularization as particular patient population. In contrast, I wanted to present a second patient with the same underlying pathophysiology, but the etiology of the presentation differing quite significantly, and the evidence base to support revascularization in this specific etiology for decompensation differs quite vastly from our first gentleman. So let's take the same similar aged early 70s male, same cardiovascular risk factor profile, same medications at baseline. In theory, at baseline, he should have the same surgical risk if we're planning intervention. However, at this point, we'll introduce a component of hemodynamic instability. Certainly, from a blood pressure perspective, once again, volume overload. And in stark contrast to our initial gentleman, there's now biochemical evidence of hyperperfusion and objective hemodynamic markers of cardiogenic shock. Of course, our first steps in investigating this patient will be the echocardiogram, demonstrating something similar: severe global LV systolic dysfunction, again dilated, suggesting a chronicity to the presentation preceding his decompensation. And he undergoes a coronary angiogram, once again demonstrating proximal obstructive coronary artery disease. So certainly two contrasting presentations. As mentioned, the underlying pathophysiology of the disease process is similar, but the etiologies to the acuity of their presentation are certainly quite different. And as a result of that, the evidence base, our interpretation of the literature, and certainly guideline recommendations on revascularization are going to differ quite significantly. I did although the focus of the presentation today will be revascularization in a stable CAD or chronic coronary syndrome population, I did very briefly want to go over the literature in cardiogenic shock. And that's because, as we all know, after caring from these patients, that the etiology of the decompensation to hyperperfusion can not be as straightforward as we like it to be, and certainly can be ambiguous in certain situations. And obviously, it's important for us to differentiate differentiate whether this decompensation is secondary to progression of their underlying cardiomyopathy. Are there dietary and lifestyle considerations? Are there non-cardiac medical illnesses that may be precipitating it? Or by far most importantly in this population, has there been a plaque rupture and is this an acute coronary syndrome? So very briefly, and speaking about at least the more intuitive and straightforward interpretation of the literature, looking at revascularization and ischemic left ventricular dysfunction and cardiogenic shock. There are only two main randomized controlled trials that I'd like to speak of, each of which has extended follow-ups which have subsequently been published, but I do want to focus on the shock trial as well as the culprit shock trial. So bringing us back to a bit of the beginning and the shock trial, which was published in the New England Journal in 1999, it's important to recognize that this was certainly one of the first randomized trials in this context, in this particular patient population. We know that even today, the mortality of cardiogenic shock is exceptionally high, but back around the time of this trial was even higher, roughly estimated around 60%. And thus substantial efforts were going towards studying interventions in this population to try to reduce that mortality. So the shock trial, multicenter RCT, 300 patients, so on the smaller side. And the patient population of interest, not surprisingly, is cardiogenic shock secondary to ischemic left ventricular dysfunction. And of particular interest was transmural ischemia, so essentially a STEMI presentation based on ECG markers. What we are comparing is emergency revascularization. The shock trial compares both percutaneous as well as surgical revascularization to immediate medical stabilization. What's important to note to interpret the results that are coming forward is that standard of care medical therapy at that time included both intra-aortic balloon pump counterpulsation. This is before the times of IABP shock, which will come later. And it also includes thrombolytics. So there is a component of pharmacologic revascularization, even in the immediate medical stabilization group. And we're looking at a nice hard outcome. So the primary endpoint is all-cause mortality, initially just at 30 days, and then we'll look at the subsequent follow-up studies, which extend that follow-up into several years. So important to highlight some of the baseline characteristics just to allow for our interpretation. Age is certainly on the younger side of things from a typical patient population when we're looking at percutaneous revascularization at the very least. Average age 60 to 65. Unfortunately, male biased, as most of the studies will be today, but more than usual actually, with about 30 to 35% females. And they do have very objective evidence of hypoperfusion, as you can see at the bottom left-hand side, and importantly, invasive hemodynamics demonstrating cardiogenic hyperperfusion. The hallmark anatomy of this patient population, as we will see repetitively over time today, is multivessel coronary artery disease, and that was certainly the case in this patient population. And then on the right-hand side, in terms of their interventions, as I wanted to mention, is that thrombolytic therapy was in upwards of 60% of the initial medical stabilization population. Almost 85% of patients were undergoing intra-aortic balloon pumps. And then about 86% of patients underwent revascularization, primarily percutaneous, but there's also about 35% surgical revascularization. For those of us seeing the trial before, the initial results might not be that surprising, is that when we're looking at all-cause mortality at the 30-day standpoint, it's actually a negative trial. There's no statistically significant difference between the two groups. If you do a subgroup analysis, there certainly is a statistically significant improvement in outcomes with patients under the age of 75. But they likely just missed the mark. It wasn't until we extended the follow-up a little bit further, 6 months, 1 year, and going forward, that we actually started to see a true mortality benefit of revascularization in this patient population. So when we pushed that survival out to 1 year, the results published in JAMA a couple of years later, we do see a 13.2% absolute survival difference with revascularization. And again, the two curves on the Kaplan-Meier start to separate just after that 30-day point. we extend that follow-up even further out to about 6 years, that absolute survival difference remains constant at about roughly 13%. And the curves themselves, the survival curves remain parallel after 1 year, which certainly makes sense intuitively, or at least is one of the first signs of a topic that we'll address a bit later, that given that there was complete revascularization in this trial, we may be revascularizing, and we're actually likely revascularizing a bystander coronary artery disease, and there doesn't seem to be a signal for benefit here in the long term, although hard to extrapolate with those current outcomes. So certainly at the time, a practice-changing trial and a guideline-changing trial, after which the recommendations at that time were for complete revascularization in this patient population. Now, there come a couple of concerns with complete revascularization in patients with cardiogenic shock. And for that reason comes the next study several years later, culprit shock, which is the initial study, and then the extended follow-up study in 2017, 2018. The concern, of course, number one, is that we've already mentioned. Are we now revascularizing bystander coronary artery disease that is not affecting either our acute prognosis or our long-term prognosis? And during the process of revascularizing bystander coronary artery disease, are we prolonging our procedures, prolonging our attention directly towards the hemodynamic instability? And as a result of prolonged procedures within the cath lab and increased revascularization, we use increased amounts of dye. And does that dye correlate to progressive renal dysfunction when the kidneys are already hyperperfused and the increased need for renal replacement therapy? So in comes culprit shock. Again, multicenter RCT, a little bit more of a robust number of patients, this time at around 700, with the patient population of interest, cardiogenic shock in the context of acute myocardial infarction. We'll now randomize patients to culprit lesion depending on clinical progression, to immediate multivessel PCI, which was mortality and the need for renal replacement therapy within that initial 30 days. And they added that outcome for the reasons that we've already explained. Patient population slightly older than in the original shock trial. So we're now in the 70s, which is a more typical patient population when we talk about percutaneous revascularization in this specific context. Again, unfortunately, male biased and more so than the shock trials, and a fairly even distribution across the cardiovascular risk factors. Multivessel coronary artery disease, which we mentioned is really that hallmark anatomy of this patient population, primarily LAD disease as the offending culprit artery, and true left ventricular dysfunction in the moderate to severe range with an average ejection fraction around 30%. Now, what we see, again, the primary outcome, composite all-cause mortality and need for renal replacement therapy at 30 days was statistically significantly less in the culprit lesion-only revascularization group when we compared to the multivessel PCI group. So interestingly, and what initially was surprising to some people, is that the need to renal replacement therapy was decreased. When we extend that follow-up, and when we extend the trial out to the 1 year mark, that difference in mortality actually evens out. So really, once again, practice and guideline changing is that we don't seem to be benefiting, at least in the short term, from revascularization of bystander CAD. And certainly in the acute presentations, we should be focusing on culprit lesion only PCI, as there's a clear mortality benefit in this particular patient population. Needless to say, practice and guideline changing, and the guidelines have reflected that and endorsed that quite strongly. And uncharacteristic of the three guidelines, when you look at the CCS, the ESC, and the AHA revascularization guidelines, they've all supported this literature with very strong class 1 indications for revascularization of culprit lesions specifically within this context, and deferring revascularization or stage PCI once the patient becomes more stable. So now moving on to a slightly less straightforward, or where the literature base is a little bit more open for interpretation, revascularization and ischemic cardiomyopathy in the context of stable CAD and the chronic coronary syndrome. And needless to say, this falls under the infamous umbrella topic of stable CAD with or without LV dysfunction, which we know it can be the bane of the existence in the topic of revascularization, simply due to the strength and the benefits that we get from guideline-directed medical therapy. It's hard to proceed forward without reminding ourselves of some landmark trials on this particular context as well, which involve Courage, published in the New England in 2007, and Ischemia, published in the New England in 2020. Now, not completely applicable to the patient population today, which I will explain shortly, but very large trials looking at revascularization versus medical therapy in stable coronary artery disease with objective evidence of ischemia. Courage was only PCI, and unfortunately, they do have a significant amount of crossover, so we'll have to interpret the results accordingly. But ischemia did look at both percutaneous and surgical revascularization. Relatively hard outcomes, MACE, composite outcome in ischemia, and death and non-fatal MI in Courage. And important to acknowledge here the exclusion criteria, not only exclusion of left main coronary artery disease, but we are excluding our patient population of interest today was an ejection fraction of less than 35%. The patient population that's being enrolled, once again, on the younger side in the mid-60s, they're all on exceptional medical anti-anginal therapy at that time. And once again, which becomes interesting, actually, when we see the results, is that there's a significant proportion of patients having multi-vessel proximal obstructive coronary disease, and also a significant amount of patients that are having proximal LAD disease. So this patient population, if there is going to be of benefit, should be the people having reduced MACE and reduced mortality outcomes from revascularization. We've all seen the results of this, and to a lot of our surprise is that when we compare these two and we look at the median follow-up, there is no statistically significant difference in those primary outcomes with revascularization. And even more shockingly, when we look at the subgroup analyses, there was no statistically significant difference in benefits of revascularization in patients with multi-vessel coronary artery disease and patients with proximal LAD disease. So the point of going over that, and the reason I wanted to introduce that topic, is that when we're talking about revascularization in the general setting of stable CAD and the chronic coronary syndrome, and specifically in the context of ischemic cardiomyopathy, revascularization really does have its work cut out for it. And that's simply because of how beneficial our guideline-directed medical therapy is, certainly in 2023, and GDMT upfront quadruple therapy, as is reflected here in the table, is certainly no exception to that rule. I really like this table here at the bottom, which is from the more recent AHA heart failure guidelines in 2022, demonstrating the numbers needed to treat of guideline-directed medical therapy to prevent all-cause mortality at 36 months. And what you'll see, two medications in particular have single-digit number needed to treat. So very impressive, and really is our focus of the medical therapy in this patient population. Now, in contrast, I'd like to review the guidelines first to demonstrate how there's some ambiguity on this topic before going into the literature. And to that, I'd like to take a few steps back. We've all seen this before. These are from the CCS heart failure guidelines in 2017. Now, of course, the two cases that I presented are demonstrating are in the context of a new diagnosis of cardiomyopathy, and we have to undergo a workup to determine that etiology. As we are all familiar with here, and certainly in the developing and lower income countries, ischemia or chronic coronary disease is by far the most common cause of cardiomyopathy, estimated in the guidelines around 60%, although certainly anecdotally and in clinical practice, it seems much higher than that. And thus raises the topic of how are we going to investigate these patients when they come in the door, or how are we going to determine or outrule an underlying ischemic etiology to their cardiomyopathy. Now, the guidelines, I'll be honest, at least the CCS heart failure guidelines are a little bit convoluted in their recommendations, suggesting that at least initially our decision of diagnostic mortality of choice, whether invasive angiography or anatomical testing versus perfusion testing, should be primarily dictated by angina or anginal equivalent symptoms, as well as your candidacy for revascularization at baseline prior to knowing your coronary anatomy. And as you can see on the right-hand side, which I don't have the pointer out, but even candidates who are considered candidates for surgical revascularization, but may be a candidate per PCI, they do suggest a primary role of perfusion imaging first. And after reviewing the literature, and very respectfully and humbly, I'm going to slightly disagree with those recommendations, as I do feel that anatomical testing, and particularly invasive coronary angiography, plays a key and essential role in this patient population, at least as the initial diagnostic modality of choice. I think we have to remember once again that the multi-vessel coronary artery disease, and that can be a limitation of with balanced ischemia, although that can be negotiated with PET, I will acknowledge, with limited availability across the country to PET viability, to PET perfusion imaging. However, more importantly, I think anatomical testing is essential in this patient population, as number one, we absolutely, at least from ischemia, have to outrule left main coronary artery disease, an obstructive left main coronary artery disease, as we know that is prognostically different than the remainder of our anatomy, and that patient population certainly has to be treated differently. And number two, I do think that it is quite challenging to determine someone's revascularization candidacy without knowing their anatomy, and the really only way that we can do that is through invasive coronary angiography. The heart failure guidelines, in terms of their guidance towards who should be revascularized, is again a little bit more convoluted, and that is simply due to the literature being a little bit mixed, which we'll go over shortly. With the initial suggestion in the guidelines that revascularization should be guided by two things. Number one, anginal or anginal equivalent symptoms, which we certainly will talk about. And number two, simply having a moderate to severely reduced ejection fraction. Unfortunately, after reviewing the literature, I don't think it's as simple as that. Moving on to the ESC guidelines, ESC heart failure guidelines published in 2021. So we're slowly getting more recent, and we're slowly starting to reflect a little bit more of the recent literature. The European guidelines do wholeheartedly embrace the need for invasive coronary angiography in this patient population as a class 1 recommendation. As we know, there's an emerging role and a significant role for cardiac CT in these patients, which they do recommend be reserved for people with more low to moderate pretest probability, reflecting the high sensitivity of the test and thus the high ability to outrule obstructive coronary artery disease in this patient population. And then in terms of revascularization, all the guidelines really have difficulty guiding us in who should be revascularized, which I think is certainly fair, but they do make a statement that if we're going to be revascularizing this patient, the benefit probably is to surgical revascularization over percutaneous revascularization as a 2A recommendation, which I think is fair to say. And finally, the most recent guidelines, or the ACC heart failure guidelines in 2020, are certainly a little bit more, definitive in their recommendations. Once again, not saying who or how do we triage people to be revascularized, but they give surgical revascularization a class 1 indication in this patient population, primarily to full embrace. And they say that anybody with a moderate to severely reduced ejection fraction who is a candidate for revascularization should do so to improve symptoms, which we'll talk about, to improve cardiovascular hospitalization, which we'll talk about, and to improve long-term all-cause mortality, which is debatable, as we'll go over shortly. At the end of the day, certainly the hallmark of this has to be a multidisciplinary decision between cardiac surgery, between interventional cardiology, and between the advanced heart failure team in the right context on who should proceed with revascularization. So three sets of guidelines at different timeframes reflecting the same literature to a certain extent, but discordant recommendations. And now we'll have a little bit more of a better understanding of why these recommendations are so discordant, and it really comes from inconsistencies and mixed findings within the literature. Although there is a significant observational and retrospective study base in this on this topic, thankfully there are actually only three randomized, major randomized controlled trials that certainly influence what we do clinically and influence the guidelines. So we'll take the time today to go through each individually a little bit more detail so that we can formulate some opinions on how we may guide revascularization in this population. So this takes us back to the original STITCH, and of course the STITCH extension study published in the New England in 2011 and 2016, specifically looking at surgical revascularization in this ischemic left ventricular dysfunction population in the setting of the chronic coronary syndrome. It's important to know at that time that this is actually the first randomized trial, at the very least, comparing revascularization to medical therapy. There were several landmark trials that are published much earlier in the 70s and 80s suggesting benefit of revascularization in the stable CAD population. But all of the studies to date, just like ischemia and just like COURAGE, have actually excluded today's patient population of interest and cardiomyopathy from their trials. So we have a non-blinded multicenter RCT, a decent size, around 1,200 patients, with the inclusion criteria initially, coronary heart disease amenable to surgical revascularization, and a left ventricular ejection fraction in the moderate to severe range, so an EF of less than 35%. We are comparing medical therapy alone, which we'll talk about in a little bit more detail, acknowledging that there is about a 17% crossover rate at the end of the day to surgical revascularization versus medical therapy plus CABG. Again, a nice hard outcome being all-cause mortality with a median follow-up of 56 months. A few important things to talk about in terms of the baseline demographics, one of which is a very cardiac surgical population in terms of age. So 59 to 60 years of age is the median age in this patient population, so much younger than our typical patients who would be considered for percutaneous revascularization in this context. Important to acknowledge that about 40% of these patients are CCS class 0. So again, the guidelines, as we went over, suggesting that symptoms should be our initial triaging factor. Almost a third to a half of these patients are asymptomatic from a coronary perspective. True heart failure, NYHA 2, NYHA class 3, and ejection fraction on average of 28%. As we keep mentioning, hallmarked with multivessel coronary artery disease, which is present in about 60% of this patient population. And then very important for us to recognize guideline-directed medical therapy at the time. So really an Achilles heel and a challenge of these revascularization studies are that to get the appropriate power in the number of patients, they need long enrollment periods. And we know that our guideline-directed medical therapy changes rapidly over that period of time. So it is really difficult for these revascularization trials to keep up with modern medical therapy. And thus the target will always be 2000, so we are well before the paradigm HF days, which is where Entresto and we are certainly long before SGLT2 inhibitors, which is the DAPA-HF and the EMPEROR-Reduced trials coming out in 2019 and 2021. Even when we look at the evidence base for medical therapy at that time, what I did want to highlight is that the use of mineralocorticoid receptor antagonists is a little bit surprisingly low in only about 1 of every 2 patients. And as we mentioned from the beginning, that's actually our medical therapy that has the lowest number needed to treat, single digits, to prevent all-cause mortality at 36 months. So not necessarily reflective of medical therapy in 2023, and there was a little bit of room for improvement for medical therapy at that time. Now, any of us who have reviewed the trial before won't be surprised by the results when we're looking at the primary outcome of all-cause mortality at 56 months. We did not see a statistically significant difference between the revascularization group and the medical therapy group. Now, we of course weren't satisfied with that result, so now we extend the follow-up. The follow-up goes from about 54 months in the STITCH trial to the STITCH extension study, which is now out to about 9.8 years. And over that 10-year period, very impressively, they had very low dropout rates, important to recognize. They had follow-up on almost 98% of patients. And again, important for us to acknowledge that there was about 20% crossover over this period of time, but we will still interpret the results as an intention to treat analysis. Medical therapy is the same. We don't have to reiterate that point. And then getting to the outcomes, which has really resurfaced and re-stirred up this debate of revascularization, this patient population, as they are able to quote a statistically significant difference and certainly a survival benefit of revascularization at 10 years when we compare it to the medical therapy group, with the average patient in this patient population living 1.4 years longer than a medical therapy, and a number needed to treat of 14. Now, there are certainly some conclusions that we have to make of this and some reservations we have to keep in mind when we're interpreting these results. Number one, and what I think is most impressive, is that the overall mortality in this patient population at the 10-year mark, regardless of the intervention, was 62.5%. So 2/3 of this patient population is dead at around 10 years, which I find exceptionally impressive. I do think we can say that there is no mortality benefit of surgical revascularization at the 5-year mark, as was published in that original STITCH trial. And then the STITCH extension study, I think we conclude that there's a signal for mortality benefit at the 10-year mark. It's certainly hypothesis generating, but it doesn't seem to be at least practice or guideline changing. What we have to keep in mind is this is a post hoc analysis of a trial that wasn't powered to have mortality benefits at 10 years. The other thing that I think we need to keep in mind, especially when we're going to compare to the next trial, is that this is a very young patient population. This is a cardiac surgical patient population with an average age of 60, and thus, again, not typically the patients that end up in our cath lab. Importantly, there is an upfront mortality risk with CABG, which we always counsel our patients on, but that mortality risk is actually 3 times the rate of patients in the medical therapy group, and it takes up to 2 years for that mortality benefit to level out. So we're revascularizing patients and increasing their mortality acutely with the potential of causing a or improving their long-term mortality. And finally, as we said, certainly not reflective of medical therapy in 2023, and thus I think that would certainly dilute the strength of our outcome with modern quadruple therapy. Now, switching over to the most recent trial in this patient population, which is revived BCIS2. And really the idea that stimulated the topic of investigating percutaneous revascularization in this patient population was just as we mentioned. We know that surgery always comes with an upfront risk and 3 times the risk of mortality. And thus, if we can do a procedure and revascularize this patient population with a procedure that has less risks, are we then going to derive more benefit in the long term? So multicenter, open label randomized trial, just like the rest of them. We're a much smaller patient population at around 60% of the size of the original STITCH and the original STITCH's trial. What we're interested in is, of course, comparing PCI and optimal medical therapy versus optimal medical therapy alone. The intention of the percutaneous revascularization in these patients were for complete revascularization. They assessed this using something called the BCIS Jeopardy score, which is a relatively modernized equivalent of the syntax score, and they were able to compare your pre-revascularization anatomy to your post-revascularization anatomy, concluding that about 70% of patients had complete revascularization. Optimal medical therapy obviously is individualized, and importantly, there's a significant portion of patients who had device therapy group as well. Primary or secondary prevention ICDs in about 18 patients with cardiomyopathies that are suspected due to ischemia with an ejection fraction in the moderate to severe range and with extensive coronary artery disease. And a topic that I have intentionally neglected thus far, as I don't think I'd be able to do it justice and really deserves an hour on its own, is viability. But the reality is that viability has always been very intimately intertwined in these trials. And at least physiologically, it makes perfect sense. If we can highlight this enriched group of patients that has hibernating myocardium or viable myocardium, our hopes are with revascularization, we can cause reverse remodeling, which has been demonstrated with medical therapy and thus improve outcomes. So viability testing and the presence of viability was an inclusion criteria for this particular study. You had to have at least 4 dysfunctional but viable myocardial segments, and the method of viability testing was left up to the individual physician. Primary outcome, all-cause mortality, heart failure hospitalization, mean follow-up at about 3.5 years. And interestingly, we will have some secondary outcomes to talk about, in particular, trajectory of ejection fraction, which we haven't talked about yet, and overall quality of life. Not to reiterate the point to too much of an extent, but again, this is much more consistent with a patient population that ends up in the cath lab. Our average age or our median age is now 70 years old. And again, important to recognize that 2/3 of the patients in the STITCH trial would have already died from their ischemic cardiomyopathy by the time these patients are actually enrolled in the trial. Fairly even distribution across the cardiovascular risk factors. Again, unfortunately, male biased, as most of these studies are. Slightly milder in terms of the symptom profile of the heart failure, so NYHA1, NYHA class 2. And important to recognize that over 2/3 of these patients are actually CCS class 0 angina. Again, reinforcing the fact that we might not be able to triage as much as we'd like and guide revascularization as much as we'd like based on symptoms alone. Again, severe left ventricular dysfunction, 27%, and not surprisingly, hallmarked coronary artery anatomy, which is multi-vessel CAD. Now, of course, once again comes the topic of medical therapy. We're now roughly 10 years later in terms of time frame of enrollment, and what has started to emerge at this time is Entresto and ARNIs. And as you can see, over the course of the trial, roughly 30 to 40% of the patient population is on an ARNI. So very significant and certainly closer to a reflection of modern medical therapy. Once again, a slightly underuse of mineralocorticoid receptor antagonism. In terms of the procedural characteristics, as we said, the intention was for complete revascularization. The average person is getting 3 stents and double vessel PCI. For those of us that have seen the trial before, we might not be surprised by this, but the primary outcome, all-cause mortality and heart failure hospitalizations at 41 months, there was no statistically significant difference between the revascularization group and the optimal medical therapy group. There are some signals towards preventing spontaneous myocardial infarction, but we always have that at the cost of periprocedural MI, which is this clinical entity that we're still unclear of the exact significance. Moving into some of the subgroup analyses, which are interesting to look at, one of which is the trajectory of your ejection fraction. So in revised BCIS2, they had baseline measurements of ejection fraction and measurements of your ejection fraction via the same modality at 12 months. And what we see, number one, there is an improvement, but the improvement in ejection fraction is exceptionally modest, and it's around the 2% range when we're talking about it specifically. And equally as importantly, there doesn't seem to be a significant difference between the revascularization arm and the medical therapy arm. In a similar fashion, the KCCQ questionnaire are an estimate of someone's quality of life, although there were original signals for improved quality of life in the revascularization population that seemed to level out over time. So what conclusions can we make from the revised BCIS2 trial? There does not appear to be a mortality benefit with percutaneous multivessel revascularization versus medical therapy in a patient population with ischemic left ventricular dysfunction, at least in this current time frame. Furthermore, it doesn't seem that revascularization will result in greater improvement of your left ventricular ejection fraction when we compare it to medical therapy. And finally, overall, we don't seem to be improving patients' quality of life. So needless to say that these trials, of course, bring up comparators between the two, STITCH and STITCHES and Revive BCIS2, because it's very tempting to hold these two trials against each other. And I wanted to highlight some very important differences between the two to reinforce the point that it's difficult for us to make conclusions in that regard. Number one, as we've mentioned, the revised BCIS2 trial is a little over 60% of the patient population that the Stitches trial was. We've talked about the age discrepancy and how 2/3 of the patients would have already passed away by the time of enrollment in the revised BCIS2 trial. Median follow-up in Stitches is almost 3 times longer than in revived BCIS2. So it's hard for us to comment what will happen in terms of mortality if we continue long-term follow-up in the multi-vessel PCI. And I think the most pertinent point is the point on medical therapy. And even with the introduction of ARNIs, if you look at the death rates at 4 years in both groups, you'll see that the mortality rates of revascularization were similar, but the mortality rates of the medical therapy group in revised BCIS2 is substantially lower. So that certainly would dilute any potential for mortality benefit. And at the end of the day, 700 patients looking at an all-cause mortality outcome in revised BCIS2 might just unfortunately be a little bit underpowered. So up until date, we don't have a trial with a head-to-head comparison of percutaneous versus surgical revascularization in this group. However, this is changing shortly. As some of us may have heard, there is Stitch 3, which is emerging currently, certainly in Canada and certainly at the Heart Institute, and is pending enrollment and is going to answer this question for us shortly. Taking the same population, moderate to severe left ventricular dysfunction of ischemic etiology, and randomizing to percutaneous versus surgical revascularization with a composite outcome. And interestingly, they will include a left main coronary artery disease population. The only unfortunate thing which is worth mentioning is I still think the question not only is PCI versus revascularization, but I still think there remains a question of the benefit to revascularization in this patient population. And thus it would have been quite nice to have a third arm comparing guideline-directed medical therapy in 2023. However, that's not the case. So some conclusions before we open up for a little bit of discussion and some take-home points, certainly for me, myself, and I hope for the rest of us as well. The mortality rate of ischemic cardiomyopathy, which is a patient population we deal with exceptionally commonly, is quite high. It's probably no longer as high as 2/3 and 60% at 10 years with quadruple therapy, but it is quite impressive. I think we could say there's a signal for mortality benefit of surgical revascularization. I think it's hypothesis generating, but I don't think it's guideline changing as of yet for the reasons that we've mentioned already. And I think there are many questions that certainly remain around the topic. Most importantly, we're unclear who is going to benefit over others with revascularization. We do have limited data on a younger patient population. Unfortunately, we not infrequently see patients in their 40s, 50s, and early 60s from this, and we usually give them the benefit of the doubt because they had the longevity to benefit from revascularization, but we don't have the data to reflect that. Multi-vessel PCI does not appear to have benefit on mortality, at least at 3.5 years. It does not appear to significantly improve your quality of life when we compare it to medical therapy, and it doesn't appear to significantly improve your left ventricular ejection fraction when we compare it to medical therapy. And soon we will have some answers, at least on a head-to-head trial of percutaneous versus surgical revascularization, with the caveats that unfortunately we don't have a medical therapy arm. Now, concluding, I think what we have to recognize is the real winner of all of these trials is medical therapy, which has really continued to put up a fight with revascularization. And as we continue to mention, as modern medical therapy continues to evolve and medical therapy in 2023 being quadruple therapy, I think revascularization, the benefits of revascularization in this patient population will continue to have its work cut out for it. Now, in the last two slides, and to bring everything home before we open up the discussion, I want to bring us back to our two patients. Similar aged, similar gender, with similar underlying pathophysiologies, being ischemic cardiomyopathy of a subacute presentation. What differs, once again, is their etiology of their decompensation, and how we apply the literature and how we guide revascularization in this population differs quite significantly. Some practical considerations, of course, as we said, is the etiology of the presentation, which unfortunately can be quite ambiguous. Is this progression of cardiomyopathy? Are there dietary and lifestyle indiscretions? Is there a non-cardiac illness precipitating decompensation? Or most importantly, is this a plaque rupture and acute coronary syndrome? Patient age, we continue to talk about, unfortunately, limited data on the younger population, which probably is the population that would have the most benefit from revascularization. On the other end of the spectrum, in our more typical interventional cardiology and cardiology patient population, is we see people in their 70s and early 80s. And thus we have to acknowledge that they probably don't have the longevity and the lifespan to benefit from a high-risk surgical intervention. Angina and anginal equivalents are important to recognize, and certainly angina or anginal equivalents which are refractory to medical therapy should certainly encourage us to revascularize this patient population. However, at that point, we have to acknowledge that we're doing it more so for symptom control as opposed to mortality benefit. There is a recurrent signal for benefit of cardiovascular hospitalizations in this population. Again, we always have to weigh the risks of a high-risk surgical intervention for reducing hospitalization in the future. And once again, a topic that I intentionally neglected because I wouldn't be able to do it justice and deserves an hour on its own, is that the role of viability will always be intertwined in this concept, and I'm sure will be a topic of studies and the literature going forward. Thank you very much, and we'll open up for some discussion.